Good morning, good afternoon, and good evening to all of us joining from around the world. My name is Katie Oppenheim, and I am the head of U.S. Government Relations at Sanofi. I am thrilled to be your moderator today because at Sanofi, we are deeply committed to going beyond the bleed for all individuals living with hemophilia. And a critical part of that commitment is addressing the profound gender inequities that persist in bleeding disorders care. This is why Sanofi, in partnership with the World Federation of Hemophilia and Reuters Events, we're so proud to convene this Hemophilia Pathmakers Roundtable. The stories of delayed diagnoses, reduced quality of life, and systemic barriers for women with bleeding disorders are far too common and incredibly timely, demanding our immediate attention and our collective action. That's why we are here today to forge new pathways for policy reforms and advance gender-specific care. I am joined by an amazing panel of pathmakers, each of whom brings valuable expertise and unique perspectives on gender inequity in hemophilia care, and many of whom have been integral to our Beyond the Bleed initiative, highlighting their lived experiences to drive change. First, we have Shellye Horowitz, a hemophilia patient who is a tireless advocate for gender equality in hemophilia care. Soon, we will be watching a short video that dives into her own personal experience. Next, we are joined by Novi Riandini, an advocate and caretaker whose grassroots efforts have greatly impacted hemophilia awareness in her home country of Indonesia. We are also joined by Dawn Rodolini, a leading expert in women's bleeding disorders and global care disparities, who serves as the Chief Operations Officer of the National Bleeding Disorders Foundation. Next, we have Danica Kelly, co-founder and CEO of MyNormative. She is an expert in gender health data, digital health innovation, and AI-driven research, and she is dedicated to closing the data gender gap in medical research. And finally, we have Daniel Anibal Garcia Diego, patient, member of the WFH board, and president of the Spanish Hemophilia Federation. Daniel is a long-standing advocate for the bleeding disorders community, focused on improving screening policy reform and equitable access to care. Now, before we kick off our discussion with our amazing panelists, I'd love to direct your attention to a short video that we at Sanofi created and that showcases the lived experience of one of our amazing panelists, Shellye Horowitz.
I knit, I quilt, I hike. What you don't see is that I've spent a lifetime struggling to access a proper diagnosis and care for hemophilia A. My name is Shellye, and I live in Northern California. Hemophilia is in 6 generations that we can trace. I grew up limping and really struggling with sports. My ankles hurt constantly. My dad was a hemophiliac. It wasn't even on their radar because I'm female. Girls don't get hemophilia, so they thought. They test boys at risk for hemophilia right away, as close to birth as possible, but girls' parents are being told, oh, you can wait until before she menstruates, and you can delay testing her. It's hard to break old understandings. We see women who can't get their medication. The insurance companies will reject it because they'll say it's for people with hemophilia. And of course, that woman has hemophilia. So I work really hard to educate other women, to educate healthcare providers, to make sure that they understand that women can get bleeding disorders and they need to access proper care. I've helped women learn how to track their periods, how to photograph any possible bleed that they have so that they can help their medical provider better understand their bleeding story. Not only is knowledge power, documentation is power. I thought my period was normal. And what I learned when I finally started tracking was that I lost as much blood in the first 3 days as most women lose over 7 to 10. I had a hysterectomy in 2018. And before the hysterectomy, I said to them, I really don't think my factor is working. Will you test it before the surgery? And they said to me, testing factors a waste of expensive medication on a woman who isn't using prophylaxis, isn't taking it preventatively. I ended up bleeding for 30 days after my hysterectomy. I used over 60,000 units of factor. A normal dose for someone my size is probably 2 to 3,000. The important thing is to not give up. If there is a woman who knows that they're having issues and bleeding, keep seeking that treatment. It's really important to follow those gut instincts. There are so many factors that may influence bleeding that we really have to stop looking at numbers, stop looking at sex, and start looking at the individual person sitting in front of us and what their life experience is.
Wow. To kick off our discussion, we'd like to start with you, Shellye. First and foremost, thank you for sharing your story and the incredible work that you do to advocate for others. So, from your perspective in advocacy and as a patient yourself, what systemic changes, either globally or locally, do you think would make the biggest difference in how women and girls with bleeding disorders are diagnosed, treated, and cared for?
Thank you so much, Katie. I'm so honored to be part of this conversation and so thankful. As you can tell, it's a topic that's incredibly personal and important to me. When we talk about global systemic changes, I think there are a few key areas that we really need to focus on. The first one is basic, but it's still unfortunately a common misconception, which is the idea that women can't have hemophilia. I can't tell you how many times, even at major meetings with World Federation of Hemophilia, where I have said to people next to me, I'm a woman with hemophilia, and they look at me in complete disbelief, even other women. And that disbelief leads directly into the second issue, which is the need for evidence, which you heard me talk about a bit in the video. I have literally had to pull out my phone and show photos of my bleeds because people just don't believe it. And I've heard things like, but you're mild. Milds don't bleed like that, more times than I can count. But they do. We do. People are imagining a completely different picture of what a bleeding disorder is like and what it looks like because I hear the word mild, and it's leaving women and girls out of the conversation, which brings me to diagnosis and specifically misdiagnosis. Our current classification system for hemophilia just doesn't work for many women. I've had bleeds, I'm on prophylaxis. I've had bleeds on prophylaxis that are more severe than some people who are classified as severe. But because I don't have that label, it affects the care I can access. So we need to rethink how we define and diagnose severity globally. And finally, something I'm especially passionate about is the delay in testing for infant girls. When a boy is born into a known hemophilia family, they're tested right away. But with girls, there's often this wait and see approach. Sometimes they don't test until menstruation, which is unbelievable to me. We know a large number of girls will have levels low enough to qualify for a diagnosis. Why are we waiting? Why are we risking their safety or a provider's liability over a simple factor test? We have the ability to catch this early, to get these girls the care and even the medical alert information that they need, and we really need to act.
Thank you, Shellye, for sharing your story and for highlighting the urgent need to change the status quo for how women and girls with hemophilia are treated, particularly around diagnosis and recognition. Your points about the misconception of hemophilia as a male disease really resonate, and that, the need for visual evidence that you shared. Dawn, I'm going to turn to you next. I know that you and the NBDF have been at the forefront of challenging these very perceptions. Given this historical perception of hemophilia as a male disease, how can specific policy changes ensure equitable care for women and girls with bleeding disorders? And what is NBDF's role in driving these changes, especially related to early diagnosis?
Yeah, thank you so much for the question, but also Shellye, thank you for sharing your story. It is so powerful. And as I listen to it, and I've heard you tell your story before, but every single time it just hits me to the core. We've got to change this. So at NBDF, everything we do comes back to four things: raising awareness, educating the public, breaking down the stigma, and most importantly, offering real solutions. One of the biggest barriers we're still facing, as Shellye really so eloquently highlighted, is this long-standing idea that hemophilia is only a male disease. You know, that goes all the way back to the 1800s when it was originally diagnosed, recognized as males were the victims of this from their mothers. So this blame and shame game is part of this. This misconception has left so many women and girls undiagnosed, overlooked, and underserved. A huge part of our mission is challenging that narrative and making sure that care is equitable for every single person with a bleeding disorder. A lot of the time, women and girls don't even recognize their own symptoms as being abnormal. So we hear things like, oh, well, in our families, my mom and sister bleed like this too. It's just normal for our family. But it's not normal. And so a big part of what we do is help people recognize the signs and symptoms, whether it's through our website, our in-person events, webinars. We're constantly trying to reach as many people as we can with one clear message. Yes, women and girls can have bleeding disorders, including hemophilia. We provide resources that define what abnormal bleeding really looks like. For example, things like very heavy periods, clots that are size of a quarter or larger, changing your pads or tampons every hour or every hour and a half. Those are red flags. Those are not normal symptoms. And we also talk about things outside of menstruation because often when you're a woman, you concentrate only on the uterus. So we look at things outside of menstruation like unexplained iron deficiency and anemia, bleeding after dental work, nosebleeds that last 10 minutes or longer, postpartum hemorrhaging, or even cuts that take longer than 5 minutes to stop bleeding. These are things that people often brush off, but should not be ignored. We also try to make it easier for people to talk to their doctors. On our website, we've got great guides and resources with the right questions to ask during your doctor's appointment, and even period tracking tools to help people document their symptoms clearly. That's often the kind of evidence that finally leads to diagnosis. It can be frustrating to have to document your period, let me tell you. I know many people that have been asked to bring in pads and tampons after their period to see if they could measure the 80 milliliters that says, oh, guess what? You have a heavy period. We would never do that if this was a man bleeding that often or that much. But the reality is in the United States, it still takes on average 13 to 16 years for a woman or a girl to be accurately diagnosed. That is just unacceptable. Everything we do at NBDF is aimed at closing that gap. And then there's policy. Advocacy is such a huge piece of the puzzle. And every year we bring hundreds of people to Washington, D.C. for our Day on the Hill in March. They meet with lawmakers, they share their stories. They put a human face and story to the issues that we're talking about. This year, with World Hemophilia Day theme, Women and Girls Bleed Too, we dedicated a full day to this topic. After we had Washington Days, we went back to the Hill and brought about 40 people, advocates, to the Hill to speak directly with Congress. And you know what? So many of the staffers had never even heard that women could have bleeding disorders, and it was eye-opening for them. And it just shows how much work we still have to do. We are making progress, but the more we raise awareness, the more we do educational things like this, the more pressure we can put on policymakers, the closer we will get to a world where every single woman and girl gets diagnosed early, treated properly, and no longer feels invisible.
Thank you, Dawn. Your insights into the systemic barriers and the critical role of advocacy in public education are so powerful. I'm based in Washington, D.C., and I will say there is no more impactful voice than the voice of a patient, somebody who truly has that lived experience. At Sanofi, we actually conducted a global hematology survey to better understand the unmet needs to advance standards of care for people living with hemophilia, including women. And in this study, we found that 59% of women were over the age of 25 when they were first diagnosed with hemophilia. You brought up the importance of equity in bringing better care for all women and girls with bleeding disorders, and that staggering statistic of a 13 to 16-year wait time for diagnosis in the US is just unacceptable and a stark reminder of the gap in data. Danica, I'm going to turn to you next. Speaking of data, as the CEO of MyNormative, your work directly addresses these types of challenges. So what specific strategies do you think can be implemented, whether using AI or digital health tools to improve diagnosis, treatment, and overall outcomes for women with bleeding disorders?
Thank you. That's a really good question. I think whenever we start talking about areas of health that are chronically under-researched and underserved, there's a fundamental role for data capture and data analysis to play in moving the needle, and also fundamentally, to Don's earlier point, in accelerating time to diagnosis and accelerating time to treatment. And so I think there's a couple of things I want to touch on that are like the baby steps, the things that if we're not doing anything today, this is what we can do to get started. And so the first thing is to disaggregate our data. So across sex and gender. So what I mean by that is when we collect information, we allow for people to identify their sex and gender in that data. And then when we do analysis, we do that demographic breakdown so that we can understand how sex and or gender may be influencing the insights that we see across different populations. This plays into other intersectional modalities around social class and ethnicities and minority populations. But in particular, as it pertains to this conversation, this is a really good baby step. The next thing that I would kind of start to push on is I think much to what Shellye and Don says is that we don't really know what we don't know about this space. And so the traditional mechanisms of data capture around even like what should a symptom look like? Yes, absolutely in your data collection, make sure that you get that data, but also allow for additional information to be collected above and beyond that as volunteered by the participants and patients in any sort of data capture activity, whether that's a clinical study or a real world evidence campaign. And why this becomes important is it starts to illuminate things such as, oh, menstrual blood is a really great marker for us. What should we know about this? Oh, there's these other pieces that we hadn't considered beyond what we would normally capture for these different kind of bleeding disorders that we should be accounting for moving forward. These may be sex-specific variables or gender-specific experiences of care and access. And these are really, really important to capture in the data. And then I think what I'm going to lean into above and beyond that, just as you brought up AI, there's a lot of excitement around AI right now, and for good reason. And if we're being positive, when we build things, we have to build them on historic data sets. And so if the historic data that we have does not account for sex and gender, and note, I actually love this because it'll come up in the little questions afterwards. It's not enough to just count women in or count people into studies. We have to measure and assess them differently. And so if we haven't done that in the historic data, any AI that we build on that reinforces the bias of existing protocols. And so to move forward, these prospective activities that create these new data sets that can be supervised with machine learning to create new insights into the field, that's the step I think that we're at in this space, and not jumping straight into AI. I think that can be quite dangerous in terms of reinforcing and reentrenching bias. And so I think if we can get our data capture right. Think about the different and unique ways in which women and female bodies may or may not be experiencing things. Get that into the data set and then move forward from there. We will have the opportunity to create incredible tools to further the field and fundamentally change not only the way that we observe women and girls with bleeding disorders, but also the ways by which we design protocols for identifying and diagnosing those populations, and then fundamentally treating them and improving health equity.
Thank you so much, Danica. That is so fascinating. And I love how your emphasis on sort of disaggregating the sex and gender data, plus the patient experience. And then I guess I would say the cautious yet strategic use of AI, sort of that combination is really important to close the data gap. Building on that, just one additional question for you. Like, what are your company's top priorities and sort of how to do this, how to address gender disparities in healthcare, particularly for conditions like hemophilia, and how do those align with, sort of our shared goal of closing the gender gap in data?
That's a really good question. So I think one of the things that I kind of laugh about with the I guess the topic area of my career is that closing the sex and gender data gap, although we all agree is very important, it's kind of this like nebulous, fluffy idea of like, okay, well, what does that actually mean when we put it into practice, and how are we actually tackling this? And so most often, and I think this really guided how I answered the last question as well, we are just looking for people who are looking to start. They're looking to do something to move forward. We're looking for these partners who understand. We have this really silly saying internally saying that the cupboards are blue, right? If you've been in someone's kitchen before, you know what color the cupboards are. If you don't even know what color the cupboards are, it's hard to have a conversation about what kind of iteration to the landscape of the kitchen needs to come next, right? So it's really important to us as we find these partners, that these are partners who are looking to make change, who are looking to move beyond just counting women and female identifying people into studies, but actually accounting for those individuals in the study process, so that we can start to push forward in a really logistical and infrastructure way to make these changes. Because I think as long as sex and gender equity are these kind of like external othered factors in the research, innovation, and healthcare process, it's going to continue to be something that can be, unfortunately, put on the chopping block when it comes to funding or initiatives, et cetera. But if it becomes a fully embedded component of every decision that's made in the process of an organization, moving a innovation, a protocol, a policy through to implementation, then it becomes something that there really starts to shrink the gap. And I think that's really important when we start looking at opportunities for improving health equity in populations that are chronically underserved and underrepresented.
Wonderful. Thank you so much, Danica, for sharing your expertise and really kind of identifying actionable ways that we can work to do this. It's super insightful and something that I think we can all learn from. Novi, I'd love to turn to you next. I'm sure much of the discussion thus far has resonated with you as an advocate and as a caretaker of someone living with hemophilia. And I'd love to hear more about the gender-related challenges facing the hemophilia community in other parts of the world, like Indonesia, where you are located. Can you tell us a little bit about your experience and how you feel like women and girls' voices can be raised up?
One of the biggest gender-related challenges in hemophilia community is simple recognition, getting people, even within our own networks, to believe that women and girls really do experience serious bleeding this problem. To be honest, even some of our board members have said, well, we are not seeing reports from doctors, especially OB-GYN, or about women having these issues. There is still deeply rooted belief that hemophilia is a male disease, and because of that, women symptoms are often get bruises of misdiagnosis entirely. I decided to start this small with a grassroots approach. I created a WhatsApp group for a woman with bleeding disorder in Indonesia. Right now, we have about 30 members from different parts of the country. It's become a really special space, a safe, supportive environment where this woman can connect, ask questions, and not feel so alone. It's amazing how powerful just being heard and can be. The group has also become a really important tools for advocacy. When I speak with doctors or our board, I can now say, look, this woman exists. They have a real stories, and we need to support them. It's not longer hypothetical. It's a personal, immediate. Right now, I serve as a bridge between the woman and the healthcare providers. The doctors aren't in the group directly, but when the medical question come up, I bring them to our board members, many of whom are physician, and then relay the answer back. It's a simple it's a simple step, but it's slowly starting to shift perceptions and educate people in the system. The next step for us is to start gathering real data from these women, things like symptom history, ages, and whether they're known carriers, because without data, we cannot push for access to better care or treatment. We are already working on upgrading an existing Android apps in Indonesia to help with this, something that can connect this woman, track their experiences, and give us the information we need to advocate effectively. And the end of the day, raising the voices of women and girls means exactly that: creating community, documenting their experiences, and using that evidence to push for change at every level, from doctors' offices all the way to the national policymaker.
Thank you, Novi. Your efforts in Indonesia, truly just creating that safe space for women and bridging the gap between individuals and healthcare providers is really inspiring. And I firmly believe in the power of community and being heard. And so thank you for sharing that. Shellye, I'm going to come back to you. You spoke really, really powerfully about the need for women to be believed and for their experiences to be validated. So based on your observations, what advice would you give to women and girls who are navigating these very complex healthcare systems around the world so that they can be an effective advocate for themselves and their own needs?
Thank you. And we have a lot of work to do, absolutely, with advocacy. And to Dawn's point, we are still fighting these misconceptions that the men have hemophilia and women are carriers that bestow the hemophilia onto men. And I just have to say, I struggle with hemophilia so much, with the complex issues that I have, and I got it from my dad. My dad was the quote carrier who passed hemophilia to me. So men can pass this on to their daughters with all the same struggles. So if there's one piece of advice I'd give to women and girls navigating complex healthcare systems, it's use pictorial evidence, which I talked a little bit about in the video. Take photos, document everything. It sounds intense. It shouldn't be necessary. But the reality is, I have been questioned by doctors, even very recently, constantly being asked, how do you know you're actually bleeding? And I always think that I want to ask them, do you ask your male patients these same questions? I live in this body. I do have the pictures to prove it. I shouldn't need to constantly expect that I have to prove what's going on in my body. And unfortunately, as women, we're questioned more, we're doubted more, we're dismissed more than we ever should be. Danica brought up an important point about research and women needing to be included in the studies, and that if we're not researched differently, then there are issues. And I've come across this myself. There's a popular calculator that is used constantly to calculate pharmacokinetics. It was perfected on thousands of men with severe hemophilia, and there are less than 400 milds in their database and less than 100 women, and my pharmacokinetics were miscalculated by hours. and not in a direction that is safe for me. So to Danica's point, it's so important that we document everything, that we check everything, make sure that the data we're given is even right. And that's why I tell people, use your phone. If your elbow swells up so badly that it looks like you have two elbows, which happens multiple times for me, take a picture. If your bruises spread and deepen because you're not getting treatment, take a picture. If you're bleeding through your pads, if you're staining your sheets, passing large clots in the toilet, even that, document it. It may feel awkward, it may feel gross, but those are images that tell our truth. And they do it in a way that words just don't. Because when a doctor hears woman or they hear mild, they already have a picture in their head of what our bleeding looks like. And unfortunately, that picture does not always correlate or match what we're actually going through. But when we show them the pictures, the picture in their head changes and it's no longer theoretical, and then it's undeniable. They can't discount the experiences that we're having. So advocate with your voice, check those calculators by hand, make sure that things line up to your experiences and your needs, but also, if you can, advocate with your camera, because unfortunately, sometimes that's what it takes for us as women to be heard, believed, and hopefully finally access the care that we deserve.
Thank you, Shellye. Advocate with your camera. That, that's the name of the game here, and, speaks volumes about not only the disbelief that women are facing, but, that pictorial evidence can be such a powerful tool to be a self-advocate in a system that's unfortunately filled with doubt. Novi, I'm going to turn it back to you. Building on your earlier comments about the growth of diagnosed patients in Indonesia and personal inspiration driving advocacy, can you share a little bit more about your personal experiences as a caregiver and how that inspired the work that you do?
Yeah, when I met my husband, I honestly knew nothing about hemophilia at all. At the time, information in Indonesia was incredibly limited, nearly impossible to find. I was just really curious about what hemophilia meant for him, what I need to do if something happened, how to support him. That curiosity led me to reach out to doctors at the local hospital. And that eventually turned into something much bigger. I end up helping to found Hemophilia Indonesia, our national foundation. In those early years, I focused on public awareness. For the first 3 years, I ran a full-on PR campaign. I mean everything: TV, radio, magazine, newspaper, and any outlet that would have us. And often I told my husband's story because at that time, so many people living with hemophilia didn't feel comfortable coming forward. There's a lot of stigma and shame, so I spoke on his behalf. When I first met him, there is only 98 diagnosed patients in the whole country. After years of advocacy, that number had grown to over 280. We just keep going. Yeah, I even turned my patient house into my parents' house into a kind of informal hotline. It was close to the hospital, and I used my personal phone, so anyone who had a question could call. Slowly but sure, our numbers grew. Today, we have around 3,800 registered people with hemophilia in Indonesia. And I will never forget the kind of question I got those early days. Mom would ask me the things like, can my son ever have a family? Can he get married? And I said, yes, absolutely. I think hearing that for me, someone who had married a man with hemophilia gave them really hope, a real hope. And I start to see more and more men with hemophilia begin to build life and family of their own. Honestly, it's all start from wanting to help my husband, but that search for answer and support turned into my something so much bigger, something that built a foundation literally and figuratively for thousands of others.
Wow. Thank you, Novi and Shellye, for sharing your incredibly personal experiences and perspectives. And just, it's incredible the impact that your individual journeys have had on the broader community. We've spoken a lot today about, how can we as a community enact change so women and girls' voices can be heard. Daniel, I'm going to turn to you next. As the director of the World Federation of Hemophilia and president of the Spanish Hemophilia Federation, you have a unique global vantage point. What are some of the most effective regional strategies that you've seen that could be adapted or even scaled globally to help advance gender equity in hemophilia care?
Well, first of all, thank you for your really kind presentation. Well, to be fair, just 5 years ago, WFH really started opening the door more intentionally to women and girls with bleeding disorder. And while in the same time, ISTH published a key paper co-authored by my colleague and friend Don Rotelin about the new nomenclature, about the new way to diagnose the women and girls with bleeding disorder. I think this is a key paper, a fundamental paper to really understand how to treat and how to diagnose women and girls with bleeding disorder. Because I don't think someone can be truly a person with hemophilia unless they are properly diagnosed and actually have access to a treatment. And that's a real big gap. And maybe it's time to ask to the hemophilia community, and for sure to the WFH, to revisit our strategy about the diagnose, the women and their will be disorder diagnosed. And from my very personal point of view at the WFH, at the Spanish Hemophilia Society, one of the most important and impactful strategy for advance the gender equity in bleeding disorder is the integration of gynecologists into comprehensive care teams. This is a game changer for the diagnosis and access to the treatment, because traditionally hematologists have led comprehensive care, but this often leaves women undeserved. In my country, in Spain, approximately 20% of the new diagnosed for women with bleeding disorder now come from our genes. And we are seeing the same results in other countries. For example, in Paraguay, where simply adding a gynecologist to the care team lead to a 300% increase in women seeking consultation and referrals to the hematologist. This is not about efficacy, as I always say. This is about saving actual lives and improving quality of life. But I need to make my point. This kind of strategy saves actual lives. Well, and also, as some people in the chat has mentioned, we also need to talk more directly about women and girls, not only with hemophilia, but with all bleeding disorders. Diagnosis rates for women, especially with hemophilia, are still incredibly low. It's hard to even get people through the door. But when we look at the data is telling us in places like Colombia, Paraguay, and even parts of the Europe and the States, women make more than 50% of the diagnosis of von Willebrand disease. But it's the same data for hemophilia is often under the 10%. These disparities should tell us something. Our approach really need to see. And well, finally, in many regions, particularly where stigma is high, a direct hemophilia or a direct bleeding disorder diagnosis can jeopardize marriage perspectives or even care fair. Let me to share with all of you some real examples from Spain. I've seen several women with type 3 von Willebrand disorder in the rural Spain traveling long distance to avoid their condition being known in their own village. They prefer to travel to other hospital quite long for their home, trying to reduce that kind of fear. And also, I have a good friend of mine, a woman with severe hemophilia A, who is repeatedly told by the emergency room doctor, it's impossible, you don't have hemophilia, because there are no women with hemophilia and there are no women with severe hemophilia. it's the same for us, and there are a lot of room to improve the education and awareness, not only among patients, also among medical professionals, about healthcare providers. And in the emergency room, there are a lot of room to this implement. And also, finally, we need to be realistic. We can use the same playbook in the US, Latin America, or Europe. We needed to interrelate different strategies in different regions, especially in that kind of regions where stigmas and other layers are challenging. It's not the same the rural Spain that the States, for example. And ultimately, one of the most effective changes we can make, as I previously mentioned, is to bring in gynecologists into the comprehensive care team, because we have traumatologists, orthopedics, nursing in the team, but we need to include the OB-GYN in the comprehensive care. We must make a space for the gynecologists, and also we need to invite the gynecologists to the table and the certain level of responsibility of dedication and other specialties. We need to make the same space for the OB-GYN that we make for the lab or for the nurse or for the surgery.
Thank you, Daniel. That was really so insightful. And I think, really your points on, the disparity in diagnosis rates between hemophilia and other bleeding disorders, plus this critical need to have gynecologists at the table, I think are really important for everybody to hear it, and truly eye-opening. I'll stick with you with one more question. Given the wide range of, contexts and, different levels of autonomy around the world, how can the WFH help empower stakeholders at the community level to drive gender equity in hemophilia care while also still honoring and navigating local customs and differences in culture?
Well, one of the key WFH roles is to empower community level stakeholders by promoting a fundamental truth. Bleeding disorder affects everyone, women and men. The president of WFH, my friend Cesar Garrido, told in the WFH Congress in Madrid, a keynote speech that for me was transforming. We won't need to keep saying hemophilia for men or hemophilia for women. We will just say hemophilia for everyone, because hemophilia and bleeding disorders affects men and women and girls and child, and we need to change our mind. Hemophilia and bleeding disorders affects everyone. But as you know, in many countries, women have been leading the change for the hemophilia care, but mostly for their sons. It's curious. The girls is changing the hemophilia care, but not by itself, but they're changing the hemophilia care by their son. And now we are on a turning point. We need those same advocates to feel empowered to speak out for themselves too. That's not always easy, especially when we spend years telling people to focus on the community needs instead of their own. But it's time to shift that mindset. Women are also part of the community, and in some countries, women are leading the hemophilia bleeding disorder community. And also, finally, just a quick comment about data, because a crucial tool for environment is the data. WFH has made significant strides in the last 3-4 years by intentionally including women in our annual global survey and the World Bleeding Disorder Registry. Data is vital and crucial. For example, at my level, at the state level in Spain, we collect data on women, especially because WFH asks for it. If WFH, they are not asking for the data, women and girls with disorder, we will be storing and exploring it. This WFH driven data collection really support local organizations in advocacy for resources at tailored care. Also on the local level, one of the most important stakeholder for sure is the government. We have to help them to see that integrating care, bringing hematologists and gynecologists together under one roof in the same table with the same level of responsibility makes sense. It's more efficiency, more core effective, and ultimately leads to better outcomes for everyone. Let me to say this thing, for everyone. This is about building new system for the scats, for scats, sorry. It's about optimizing what we already have. Because by providing robust data, advocacy for integrated care models, and empowering women to claim their own health, WFH can truly drive gender equity, and serving every person with a bleeding disorder, hemophilia, or bleeding disease, any kind of bleeding disorder, in seeing her, treating, and diagnose in a correct way.
Thank you, Daniel, for those thoughts, particularly on the need for women to advocate for themselves and not just for their family members, and the need, kind of underscoring Danica's comments earlier on the need for data and, how that can really help to drive gender equity. Dawn, I'm going to turn it back to you, and then you can sort of kick it off. And then after your response, I'd love to give everybody on the panel an opportunity to weigh in on this question. So, you shared your own powerful story and the NBDF's work, that's deeply rooted in addressing gender inequity. So I'd love to know, how has your experience with the NBDF shaped your strategies for addressing gender equity and bleeding disorders? And what are some key takeaways that we can, that can be applied more broadly?
Yeah, thank you for that. And I want to thank everyone for sharing their examples and their stories. When I hear stories like Novi's, and I've known Novi for a long time, and I've seen her advocacy at work, and her being able to show in metrics, being able to say we started at this number and now we're at this number over a period of time, that really shows that grassroots passionate advocates can make a difference. So when she shares that even her board of directors struggled to accept that women can have bleeding disorders and they are also physicians, it shows you that it just really drives home how deep the misunderstanding runs. This isn't about taking attention away from men and boys with hemophilia. It is about making space for women and girls who are also bleeding, often just as significantly, perhaps in different ways, but also the same ways, and with zero recognition. And I want to highlight something Daniel had said. Moms, sisters, daughters have been advocates for men and boys with hemophilia since the start of time. And since the 1800s, truly, many women are leading the organizations, starting them, driving this like Novi did. And when I think about this, I really want my call to action to be to the men and the boys who have moms and sisters and friends in the community, that they start recognizing and lifting up the women and girls with bleeding disorders, not just hemophilia, von Willebrand disease, and platelet disorders, rare conditions. It's time for the men to join us, step up, and help lift our community up. One of the biggest barriers we're up against is that women, as we've talked about, have been systemically excluded from clinical trials and data collection. It's happening everywhere. All countries underdiagnose and underreport bleeding disorders in women. And that lack of data feeds this cycle where women's symptoms are dismissed. I mean, just personally to share, I was 59 years old when I was finally diagnosed as a symptomatic carrier, and was told that throughout my life I've had 4 different factor levels. I have factor 9 deficiency in our family. I was told that's not possible. What assays did they use? Challenging my own data. Well, that can't be possible. 2 were in the mild range and 2 have been in the normal range, but it didn't matter my levels. I was still bleeding. And so concentrating, like Shellye said, on the numbers versus the symptoms allows for the dismissal of this. This year, I finally had my first comprehensive clinic visit at the age of 62. And I now have my first dose of factor at home, so that in case I have an urgent bleed, I am able to treat. That's progress, but just shows you what a long road this is. I have been advocating for bleeding disorders for almost 30 years, and I myself was not a good advocate for myself. So just to call it out, it's not easy, but we've got to raise our voices. So how can we change this? Again, going back to the stigma, first we have to have conversations and make the word in any language, however you talk about it in your country. In the United States, period is the most common word used. Let's use the word period. Let's make sure that we normalize this conversation and talk about what's abnormal and what's not. It's not just in medical settings, it's actually in our communities. Like Novi said, they created a safe space to talk about this. Now let's create an opportunity to educate people on how to talk about this to their school nurses for children, to their OBGYNs, to Daniel's point, the gynecologists, to general practitioners. Let's start to normalize saying, I'm having heavy periods. I've learned this is not normal. Instead of using terms like menorrhagia, which are complicated, people don't necessarily know what that means, make it accessible. We have to talk about period poverty as well, because this is impacting globally, worldwide. Period poverty is a major issue. Taxes and the prices of menstrual products mean that it is very difficult for many of our populations to access them. In the United States and in many states, menstrual products, period products, are called under the umbrella of luxury products. I will beg you to ask any woman if she feels that using pads or tampons should be a luxury. No, it is a necessity. This is about health, and it's about dignity and economic equity. So we can't ignore the data from clinical trials. Acknowledging that recruiting women for hemophilia clinical trials is challenging. I acknowledge that. There are a lot of complications with that. But just to highlight this, so out of more than 4,500 participants, in fact, it was 4,503 participants in hemophilia trials over the last decade. This is in the United States and globally. Guess how many women were included? 5. 4,503 people, 5 were women. That's not just a gap. That is a gaping hole. We need manufacturers and researchers to include women, even if it's a clinical trial and you do a sub-trial. We need this data to be included. We do not fully understand how menstruation, hormones, different organs, and pregnancy interact with the treatments that have been built and tested only in men. We have no idea why one product works differently in one person to the other. We definitely don't understand how they impact with women's hormones and women's organs. We just don't respond in the same way. It's just the fact. And it's often brushed off as an overreaction. Well, my men with hemophilia do just fine on this drug. It must be in your head. And that is the dismissal. Instead of really what it is a biological difference. So if I could break it down into action steps, here's what I would say. Count women. I heard it from Daniel. I heard it from Novi. Data is king. If we don't have data, we're never going to get to the place where we can get diagnosis, access to care, and treatment. So start with your carriers. If you haven't started anywhere, you know your people who are carriers. Start there. Include daughters of men with hemophilia. Anyone showing symptoms, anyone that has more than one child with hemophilia, they're a carrier. Start there. Educate. Share the signs of bleeding disorders in women loudly and clearly, and put it in terms that people understand. Don't use complicated terms like menorrhagia. Use the terms that are used in your culture, in your society, and in your language. Organize. Create women's committees and patient advocacy groups. India has an amazing model where it started with a women's committee and it spread. And India is a giant country. And they have more than 100 chapters throughout India. That women's committee started small, it started to grow, and now they have a national women's conference every year where people come from all over the country to learn how to tell their stories, but also learn about the treatments that are available and the signs and symptoms, and advocate. Take the personal stories from your country, from your area, straight to the ministers of health and the policymakers. Talk about the impact, the direct impact on women's lives. How does it impact school? How many days do they miss because they can't go to school because of their heavy period? Work, relationships, intimacy. All of this is what really moves people because now they can start to put it into context. So data along with storytelling is key. And we have to keep pushing because if we don't, in 5 years, we will be having the same webinar, having the same topics. And in 10 years, if we don't change it, we will be having the same webinar and the same topics. It's time for us all to work together, men and women, leaders in all organizations, globally and locally. Thank you. Sorry, soapboxy.
No, that was amazing, Dawn. I mean, I loved your, call to action for all of us. And thank you for that and for the work that you and the NBDF continue to do to push forward, to support women and girls. As I had mentioned, I'd love to give everyone else an opportunity. And before I do, just a reminder to put questions in the chat because we are going to have time for Q&A at the end. So let's go, Shellye, let's go to you next.
And I just want to say I always love hearing Dawn speak because she synthesizes so well all of the information and the struggles. It's definitely not a soapbox. If it is, we're all on it. I think it's just such a powerful voice. And so many of the things that Dawn shares resonate with me constantly. She talked about research and the fact that there's no women in research. All the medications are researched on men. And then there's this assumption that if we're women or mild, we can't struggle. Last week, I did a trial on medication number 4 because my body is clearing faster than it should. And I'm female, so they assume that doesn't happen. And I also want to note just what we've heard in this conversation. Dawn told her story. She was diagnosed as a symptomatic carrier at age 59. I got an official diagnosis of hemophilia at age 45. My sister also getting hemophilia from our father, age 42. And in this webinar, we talked about how ridiculous and scary it is that it takes 13 to 16 years on average for a woman to get diagnosed. I just want to point out that is taken, most often we quote a CDC survey that actually looked at 75 women with von Willebrand disease who had made it to a hemophilia treatment center and were getting care. And that's how we got that 13 to 16 year, that's how we got that data. However, we know an article published a little over a year ago that it is estimated that over 1 million women worldwide are impacted by hemophilia, most of which are not on the radar. And we know that there are millions of people worldwide who have hemophilia or who have von Willebrand disease who also aren't on the radar. So I would argue that 13 to 16 years for most women is actually a lifetime, that they never actually get diagnosed if we're truly looking at the statistics and reading them well. And that's just terrifying and something that I think we need to step back and really understand as we quote these other statistics, that we actually may be even minimizing female experience with the statistics we quote. Now, beyond everything that Dawn mentioned, I cannot continue to stress enough the power of pictorial evidence. Documenting our symptoms with photos, even when it feels awkward, is often what it takes for us to be heard and believed in a system that doubts us and minimizes us and doesn't study us as women. So keep in mind that your camera really can be one of your most powerful advocacy tools when all else fails.
Thank you, Shellye. Novi, let's go to you next.
Yeah, for me, it's about creating community and documenting experiences. Start small, like a WhatsApp group, to give a woman safe space to connect and share. Then use those collective stories and data to bridge the gap with healthcare providers and push for change at every level. Community empower advocacy.
I love
Yeah.
that. Thank you for that. Danica, we'll turn it to you.
Yeah, I think I might take a little bit of a different, I think that's maybe the theme of today, a little bit of a different bend on this, on the answer to this question than some of the other folks in the room. But I agree, I think, on the fundamentals of like data capture, formulating arguments, et cetera. But when I think about the question around like making sure we're ensuring access, I think access can be broken down to a couple of things. So one is access to diagnostics, right? And so I think when we think about ensuring access to diagnostics, we need to fundamentally change and train new physicians and physician researchers on what that is and what the new kind of gold standard or industry standard should be. So I think there's like a fundamental, and I mentioned this earlier, if oh, this is the industry standard, but if you're a woman, here's this other thing, that's not an industry standard, and that's going to continue to perpetuate the problems that we have. And so I think working with clinician researchers to do the work that we need to do to create new standards of care and of protocol and of diagnostic process is going to be a fundamental shift that's going to ensure, quote unquote, access to the diagnostic process. Separate to, and then above and beyond that, is access to care, right? So then that can be in the form of physician access, that can be in the form of interventional access. There's a bunch of different kind of components there that we can talk about. And so if we, I think that the upstream work that got done on like, what do we need to understand from a symptoms management or experience management or lived experience management, which would like Novi and Shellye and Dawn have talked about so much. If we can make that into the system, get it through kind of the quantification of self and the clinical validation process, then we start to have a data set that we can actually work with folks to design new protocols for that are accessible to the community more broadly. And I think this can be both in a self-monitoring context as well as kind of an interventional one, whether that's pharmaco or any other kind of like interventional space. And I think it's really, really important that we start with that clinician researcher-led research. That's a really meaningful solution because then you have the data that's, unfortunately, and we talk about like the bias and the stigma and stuff. No one listens to women. No one cares. So in order for us to quote unquote legitimize all of the lived and embodied knowledge that we have, we need to transform this lived data into clinical data. And then that clinical data needs to become protocol and policy. Like this is this transformational access effect that we need to kind of foster. And I'm not saying that it's because it's better or right, but when we talk about increasing access and fundamental change, it's not about, for me, always what is like the moralistic imperative in terms of like what is, we should just be taken at our word. Knowing that we're not going to be taken at our word, how do we enter the system and kind of fight it from within? And I think that's so much of what we've talked about on the data capture side today.
Thank you, Danica, for that. And last but certainly not least, Daniel.
Well, let me to share with all of you just two key takeaways to my idea. The first of all is the power of data. I was thinking, I was recalling in 2012, we communicate our very own database on rare bleeding disorder, and unexpected finding that we have more women with rare bleeding disorder than men with rare bleeding disorder, but we are not organizing any kind of action to the women with rare bleeding disorder. And when you have the ability to explore your own data, maybe you can find that kind of unexpected finding. And since 2012, we changed the way we're dealing with the rare bleeding disorders, because at least in our community, the most common figure of a people with a rare bleeding disorder is a woman with a rare bleeding disorder. And my second thought, my second key takeaway, as I probably mentioned, I think is most actionable step for a community level stakeholder is the absolute necessity to integrating the inlcuding into comprehensive care teams. This is a simple, easy structural change that has a dramatic impact on the diagnosis rates and the access for women, as demonstrated by, as previously mentioned, the data in Paraguay. That kind of huge chain threefold increase in consultation and referrals in Paraguay. We must strategically adapt our approaches to include relevant specialists, broaden our understanding of all bleeding disorder, and directly confront the stigma to ensure women are properly diagnosed, seen, and treated.
Thank you, Daniel. And thank you to everyone for the amazing insights and actionable steps today. I mean, from pictorial evidence to data to, the integration of gynecologists to the power of grassroots advocacy and community, this has just been such a thought-provoking and powerful discussion. Now I'm going to go into the Q&A box. First question. From Patrick James Lynch, from a US NBDF perspective, is there a real solution related to federal policy that would cut through this antiquated thinking regarding hemophilia and women and help to ensure access? So Dawn, maybe we'll start with you and then others can weigh in.
Yeah, sure. Thanks for the easy question, Patrick. I appreciate it. Look, it is going to be step by step. I think that we've got to start with our data. We've got to start with prevalence of what we know, not necessarily the diagnosis numbers that we've captured. So to Shellye's point, sometimes we do ourselves harm by quoting old studies and reports. But I also think that without data, we get dismissed. And so I think that using prevalence numbers, to Shellye's point, there are definitely more than 1 million people that could be diagnosed and are not diagnosed. And we know those prevalence numbers based on some really good studies. So I think you start there. I think that we then need to find champions in the lawmakers' committees that are champions for women's health and educate them about the struggles for women and girls with bleeding disorders specifically. And finding those champions who are on committees, then educating them and helping them become part of our team, so to speak, so that when we bring the stories to Washington Days, when we work on policies, when we address these, when they pop up and we say, ooh, that's harmful, either at the federal level or at the state level in the United States, as you know, we've got a pretty complicated system, then we've got those go-to champions that can stand with us. So I think that's one area. I also think that the med-ed partnerships, educating healthcare providers is key. And so while that's the policy question that you asked, that's what I was talking about before, but I'm hearing over and over and over again that it's the healthcare providers that aren't understanding, or that is also a real barrier. And so I think that there's some real partnerships with OBGYNs. I've heard some great outreach grassroots projects delivered by chapters. And finally, the Foundation for Women and Girls with Blood Disorders is a pretty incredible organization that focuses on specialized clinics for women and girls with bleeding disorders, and also educating healthcare providers. They've got amazing resources on their website. So just to shout out a different organization that is really doing great work in this. So that's the start, but certainly that's not the only answer.
Thank you, Dawn, for that. Anybody else want to chime in? Okay, Dawn covered it all. All right, our next
or it's just really hard.
Or it's really hard. Okay, next question in the box. Daniel, I'm going to kick this one over to you. The question is from Kate Green. What possibilities are there for joining broader coalitions globally and locally for women's health that can accelerate our advocacy?
Well, this is a really interesting question, because maybe we need to change our mind, because we need to advocate for the women's health and for the gender equity in all the healthcare system, not only in the treatment of hemophilia, the bleeding disorder, in the access to the GPs, to the access to every kind of aspect on the women's health. As Dawn previously mentioned, at least in my country, the poverty is a key issue, because as Dawn mentioned, the period product has the same taxes and the same VAT than the cosmetics. It's a saying, is unquestionable. That's why maybe we need to change our mind, and we need to get involved in broader coalition, intended to change the women's health, and as also in all the levels of the healthcare systems, because I advocate to the inclusion of the OB-GYNs in the comprehensive care teams, but also we need to change the way that the general practitioners treat our women in their entire levels, not only the very specialty levels, because it's a saying, if we are able to include our OB-GYN in a very high top level of care, but when you are facing in the other kind of women health situation, and the GP and the other kind of healthcare provider has not the same mindset to including the comprehensive care of the women's health. That's why I think it's a key point to get involved in a huge coalition intended to change the way the healthcare system treat the women's health.
Thank you, Daniel, for that. All right, Danica, we got an AI question. So you're up. Oh, Dawn, sorry, go ahead.
Quick?
Please,
I'm so
yes.
sorry.
No,
I
please.
was just thinking about this and just for your information, I chair the International Women and Girls Committee for the World Federation of Hemophilia as well. So I was thinking about the coalitions. The other thing is reaching out to other diseases, other groups. Building coalition across diseases sometimes can bring many women's voices up. So thinking about what you have in your country as far as other diagnoses and partnering with those might be a way to get better and bigger attention when it comes to being dismissed, because it's not just in bleeding disorders that women's health is dismissed. So I just wanted to call that out, just as a thought from the committee.
And a great thought it was. Thank you, Dawn, for weighing in. All right, Danica, we're kicking it over to you. How can our community join the broader conversation and advocacy around responsible AI in healthcare?
Okay, that's a doozy. So I think there are there are a few ways that I could tackle this. I think I'm going to start at one philosophical end and then follow it through. So I guess the good news is that usually AI is not AI for AI's sake, if that makes sense. And so when we talk about AI, it's kind of like the sex and gender data gap, where we're like, this is this nebulous thing that's like impacting us all. But AI is actually both not that complicated and also far more complicated than I'm comfortable with. So when we think about the not complicated part of AI, it is integrated into the systems that we use on a day-to-day basis, whether it's the machine learning or the AI algorithms in our social media platforms that we use, or it's the administration software that we use in our jobs. AI fundamentally is just infrastructure that is in the workflows that you use, right? And so this can be in the research context, this can be in the healthcare administration context, this can be in the algorithms in our social media feeds that inform what we see and what we do, that include health content. That there are so many places in which AI is present in our lives. And so when we talk about kind of being a part of our advocacy around responsible AI for health, I think that the short answer is kind of regardless of where you are in terms of your career or your personal life or whatever you may be doing, there is AI that you have direct control over, which is an incredible and powerful thing, right? Your Instagram algorithm, if that's your preferred social media platform of choice, you can feed data and preferences in it to populate it and push good content forward. That is an incredible power from a platform perspective. It is an arduous task for sure, but you can curate that AI so that it is not only suiting your personal preferences, but also giving good attention to good content around health and pushing it in terms of popularity. That is an incredible, free, resourced, community impactful kind of way to start pushing on AI from the comfort of your phone or your computer in your personal life. The other spaces in which we can kind of see it is one of my favorite ones that I like to push on is in procurement. If you are in a job that buys stuff, any sort of software stuff, making sure that there's a gender-based assessment or sex as a biological-based assessment in how that technology treats data as it comes in will fundamentally underpin and change the ways by which machine learning and AI are developed in that platform. And so having a GBA plus, like a gender-based analysis plus program embedded in your procurement practices, your protocol development practices, et cetera, will fundamentally change the data ingest that occurs, that informs the algorithms, that develops the machine learning that turns into AI. There's this kind of like iceberg that lives under the AI that is not actually that complicated, that we can all really easily start to advocate for, regardless of the roles that we play in our cultures and societies, which I think is really phenomenal and empowering. And then when you start to talk about like getting that conversation out into the public, making sure that you feel comfortable having these conversations in your personal spaces and in your professional spaces to push on things, but then also like even with the organizations that are in the room today, this conversation is an outcome of people taking those internal conversation and turning them outwards so that other people can see them and push them forward. And I think that's when we start to see, okay, now we have 100 plus of us in a room talking about ethical AI, talking about sex and gender equity in the AI process. We're all here being a part of this. What is it that we now do to kind of, we talk about snowball sampling, to kind of roll this into creating something bigger? And so continuing to stay in contact with those stakeholders in this room to push this conversation outwards and have meaningful impact, I think is a really beautiful thing to, again, start pushing on how we as a community broadcast, think about, perpetuate and start conversations on ethical AI and health.
Thank you for that. Anybody else want to chime in? Okay. So our next question, Zubair from Pakistan asks, and this one could go to Shellye, to Dawn, to Danica, so I'll let you guys decide who wants to kick it off. I would really appreciate some insights on how to provide awareness, even to the women from underprivileged areas where the system is already tackled with issues such as a lack of basic education, patriarchy, and absence of technology in countries like Pakistan. Are there any AI projects undergoing to reach to the unreachable? And how, from the perspective of the US or NBDF, have these types of gaps been bridged over time?
I feel like we need to chunk this because all three of us probably
question.
have different awareness levels. I certainly can't talk to AI, and Dawn, of course, is the best person to talk to the NBDF. I think I can talk about the systemic issues and the patriarchy. I think we all can. And I really see this as a two-pronged approach, right? We have working with individuals who have bleeding disorders and may or may not have a diagnosis, and then working with their healthcare providers. I think with the individuals, we have to combat a lot of different things with women, including imposter syndrome. We've always been told that we don't have this, and even today, sometimes with all the issues I have, I still feel like an imposter in a man's world, and I think that that can be part of it. I think women look at their sons bleeding with severe symptoms or symptoms that may look very different than theirs because the boys don't menstruate, and they feel so guilty because our systems have taught them that it's their fault for passing it on, that they don't even think about caring for themselves. And we need to understand that men give it to women, women give it to men and women, and it just is. This isn't about blame. It just is. It's genetics. And no one is at fault. And we need to get rid of that guilt and that shame and start to look at all the symptoms as being valid and important. So that's the patient approach, and letting them know that they're valuable and they don't have to suffer, and that they actually are suffering. Because the other issue is when we've been taught to ignore this for years. Dawn and I have both been in this situation. You just learn to ignore your pain and move on because that's what we were all taught to do. So we have to unlearn years and years of pushing things aside. So that's the patient aspect. Also, if we educate patients, we can educate them for years and years, but if they hit a brick wall when they go to their provider, oftentimes they stop. And that's the end of the conversation. So we also need to really work on that provider prong and make sure that our providers are educated and understand how amazing would it be if in every country the providers are seeking out our carriers, as Dawn mentioned earlier, if the providers are seeking out the mothers, the grandmothers, the aunts, the sisters, and they're initiating, that helps get rid of that guilt and shame, because it's coming from someone who's seen as more of a position of authority. And, I've seen it when I had 14 breakthrough bleeds in a year. A provider said to me, "How can you possibly be bleeding, Shellye? You're on prophylaxis. Prove it." And imagine if that provider had instead said to me, "Shellye, this is too much. Let's do research." It wasn't until 10 months after I made that statement where I asked for the testing that we discovered my pharmacokinetics were a mess, and I was once again rejecting a factor product. And that's why I was bleeding. There was a clear explanation, but we questioned the women instead of looking for the data. So we always are starting with doubt, even seasoned professionals who should know better. And I've run into tons myself. So I think it's really, really important that we look at educating patients and simultaneously helping providers understand how they may be able to take the lead to get more women on a radar globally. And with that, I need to pass it to my esteemed colleagues who can better answer the other parts of this question.
I too am not going to tackle the AI thing because quite frankly, that is definitely not my area of expertise. And I don't know how AI projects are reaching. Sorry, the question just jumped. But I don't know how they're reaching the unreachable, basically. So what I will talk about, though, is my experience in Pakistan specifically. I had the privilege of going to Pakistan and working in and presenting in a women's workshop. What I will say from a Pakistan standpoint and going into some of the areas in Pakistan where the system is, excuse me, where people are lacking basic education, they're not informed, and they're really lost. You have some incredible champions in your hematologists that are living in other cities, but I know would partner with you. So Tahira, who is an incredible hematologist and a champion for women and girls with bleeding disorders, reach out to her. You can do that if you don't know who she is. You can reach out to your Pakistan national member organization. Masood is the CEO of that organization, and he too is an incredible champion for women and girls with bleeding disorders and understands the culture and the barriers specific to your area. What I would say to you from the other side of this, you don't have to be highly educated to talk about your own symptoms. Practice. Allow the women in your area to have the opportunity to come together in a women's group or a women's committee to practice telling their story, which includes their symptoms, in a way that they are comfortable. The first time you tell your story, it's never going to be the whole thing. The next time you tell your story, a little bit more gets added. The next time you tell your story, it's practice. We don't do this naturally. And so it is purposeful practice. It's giving them talking points. If they go, "I don't know how to tell my story," interview them, ask questions. Tell me the first time you realized you had a heavy period. Tell me the first time you bled longer than 7 days. Tell me the first time you had a joint bleed. Whatever those symptoms are, interview them, get them to capture it, and then start to practice telling that story. The final thing I would say in Pakistan is you have a lot of men in the country who are now finally becoming aware and want to be your partner and champion for women and girls with bleeding disorders. Masood, as I said, being one of them. That's where I would start because I understand the patriarchal system that exists, and you need sometimes to have that partner to allow you to have a voice. Is that fair? No, but it is. So let's work within the system and not let the system be the barrier.
Thank you, Shellye and Dawn. I cannot believe how quickly the time has flown. We have time for one more question. Novi and Danica, I'm going to turn this one over to you two to sort of close us out. The question is from Taiwo Adurmi. How do we integrate culture and tradition to advocacy and intervention on girl and women's gender healthcare, where culture and tradition are placed with high value.
Do I need to go first or? Yeah.
Novi, you're welcome to go first.
Okay. Yeah. Well, from my side is we start to with the culture understanding, not assumption. Do deep ethnographic work, understand local value, taboos, gender rules, and traditional belief around health, menstruation, fertility, childbirth, mental health, etc. And the second one is identify what already works. Some tradition may actually support women health, example, postpartum rest, herbal care, build on those, we can do it. And then the second one, involve local gatekeepers, like influencers. Work with religion leaders, elders, and traditional healers, not against them. It's like, for example, in Indonesia, we have a problem with the circumcision because most of us, majority, it's Muslim. So yeah, what we are doing is we asking the opinion of the religion leaders who really knows about the knowledge of the Muslim Islam. And then frame women health as a community well-being is an example, healthy mothers raising strong children, and use respect the voice to legitimize the interventions, especially in setting where outside influence may be mistrusted. Then culturally reframe the message, probably, and then use participatory approaches, and then probably leverage culture, art, storytelling, and practice. Yeah, this is, I think it's work for this problem.
Thank you, Novi. You want to close us out?
Yeah, I'll be super, super quick. I think much to just like build on what Novi said from like a systems and research and protocol and like how we embed this in the systems, all of the topic areas, ways of working that Novi just indicated are real valuable data points and should not be excluded from the data set, right? So as long as we continue to other traditional ways of knowing that may actually be more effective and efficient than the Western scientific ways of knowing, we are continuing to maybe unknowingly, unintentionally throw out really, really good data and data that already aligns with ways by which people are naturally thinking about their bodies, which means that's the way they're most likely to self-report. That means they're the most likely way that they're going to self-represent and are representative of the pain points that they're experiencing in their life and things that we should be addressing from like a quality of life impact assessment kind of way. And so those data points are not outside of clinical validated data. Those are the data points we need to pull in so that we can understand and interpret them from a clinical perspective and then provide meaningful and effective services back into communities and groups like the work that everyone in this room is doing, and actually have the sort of integration and health impact that we're looking for. So I just wanted to make sure I said like that is real data that needs to be built into AI too, and not just like Western scientific data.
Thank you, Novi and Danica, for those insights. And thank you all. This has just been such an incredible conversation. We're going to close with a question for the audience. But before we jump to that, I just wanted to quickly share that Sanofi has partnered with Believe Limited to create a new documentary film called Dismissed. Dismissed focuses on the stories of 5 women who challenge the norm related to living with chronic bleeding disorders and demand, recognition, care, and justice. The trailer was released on April 17th on World Hemophilia Day, and the full documentary will be released in August during NBDF, BDC. We look forward to continuing to share these stories as we are all working together as a community to increase awareness and create better outcomes for women and girls with hemophilia. So now, to close, I want to ask the audience a question. What can you commit to actioning now to advance gender equity to better the lives of women and girls with bleeding disorders. You should see the poll popping up on your screen. So tell us what you think, and what are you going to commit to doing? So question number one, count women in studies, registries, and other data. Number two, educate on the signs of bleeding disorders in women. 3, create women's committees in patient advocacy groups. 4, take women's stories to health ministers and policymakers. Or 5, talk about the impact of bleeding disorders on women's lives. So cast your votes if you have not already done so. Give you a few more seconds to vote. We will close in the count of 5. Okay, let's see the results. And the winner is number 5. Talk about the impact of bleeding disorders on women's lives. Thank you all so much for your time today. A few housekeeping items to close. You will get an email in the next couple of weeks with a recording of today's event. There will be the original English version. There will also be Spanish and French translations. Please think about who you want to share this with so we can, take all of the amazing insights and learnings today and share it with a broader audience. Reuters will also share some additional resources to help you bring about the changes that we talked about today. It was a privilege to be here with all of you. Thank you to our panelists. Thank you to everybody for attending. And please stay tuned for future Pathmakers events. Thank you guys so much. Have a great rest of the day.